Thank you very much, Vladimir. And I will go very quick. This is the last, everybody tired. And my friend Miguel will talk already. And I just continue what you talk. And Tom clearly explained to us about the anatomy of the foot ventricle. So we are so stressful in Indonesia, and then we need refreshing, go to the Komodo. Next time you come with me to Komodo. Okay, so brainstem cavernous angioma, we just need to understand the characteristic. This is a vascular anomaly that presents as sinusoidal-like capillary vessels and regarded as neoplastic. And most of the cases, location is fossa posterior and mostly in the pons. So this is our cases of handling Cavanoma, and this the anatomy already clearly explained by Miguel. I don't need to repeat. And we just want to see where is the safe area if we need to approach from posterior, because again, Cavanoma is always sometimes mandatory from the anterior or anterolateral, and sometimes mandatory for the posterior, but sometimes in the gray area. Gray area means that you may approach from the posterior, you may approach from the lateral or anterior. Both has a positive and negative sides. And again, need to understand where is the safest area to go. So this is the complication we need to understand, that we should not injure the tract or nuclei in the brainstem and cause complication. And also the surgical indication, we need to know the exophytic evacuable lesion, rapid progressive neurological deterioration, mass effect, and also multiple debilitating hemorrhage is indication. So which approach again, anterior or posterior? Again, both there are a positive or negative. So sometimes the anterior, we need to avoid direct threat again to the nuclei or the tract, because when we injure that may cause another neurological deficit. And also in the anterior, the negative thing is the window is quite narrow compared with posterior, because posterior, when we go posterior, we can have a very wide angle to see everything more clear. So if we meet the rupture of the cavernous angioma, what's happening? So if the rupture is inside the tumor, so the patient come to us is like a mass evac. So sometimes you know that the bleeding come out from the weak wall of the capsule and make creating so-called a halo sign. You can see here, this is a very clear halo sign. And this is need to be understood to all of the colleagues where to refer to neurosurgeon, because halo sign means there is the best time to remove. I will explain later to you. So again, halo sign, this is a case of other patient who came with me already 3 months after bleeding. Means that the halo sign disappeared already. You can see here, this is becoming not clear. Of course, still surgery the answer, but the tactic is completely different and much more complicated because everything reattached to the normal brain tissue. This is the mixed density appearance. You can see here, layers here, meaning just bleeding a couple of times. This was, the debilitating multiple hemorrhage inside this indication to do something surgery. So this is after surgery and then 1 year after surgery. This is subacute, you can see here. This is also indication to do surgery as soon as possible. And also when the patient gets a severe neurological deficit, mostly the cases in the medulla. So that means we need to consider to do it as soon as possible in the medulla. So sometimes bleeding only remains small lesion, and sometimes we just need to observe. So this is some cases I'm going to show to you that this is the first case I did 2001 in Indonesia of the brainstem cavernous angioma. So again, this is so-called a halo sign. This 23 years old male with quadriparesis and paralysis multiple nerve. And again, when you see these halo signs, means there is like a oil like oil around the cavernoma capsule. So once we touch the capsule, means that we can easily remove. We will show you the photo. This is the patient and these poor people. And from that case, we built so-called the Indonesia Brain Foundation to help the poor people who has a good prognostic. So patient with the prone position, and again, I select this prone position posterior approach. And you can see here, this is a very old video. So see, that is the pons, the positive good from the posterior, you can see huge angle. So you can see after splitting, we can see directly the cavernoma. And once we touch, we pull the capsule, you can see actually I did it unintentionally, just put it just like a baby born. Why? Again, because this is a halocine, because the capsule covered by oily. So that's when we pull out totally. Again, well, it's quite rare, we can see here, but again, we need to teach the young generation. When we see the halocine, that is the best time. Do not wait. Because again, when we wait, halocine will disappear means that the cavernoma will reattach to the normal brain tissue. And of course, this is more difficult. So this is post-op. And you can see here, this is halocine and the left side, unclear halocine. Unclear halocine, of course, also surgery, but you see, we cannot remove as the former case because we need to piecemeal surgery because already reattached. So this is another case of female with a hemiparesis with a fourth nerve palsy, and we did surgery. You can see here, this is quite huge cavernoma, and we did it already with subtentorial transtentorial. So this is a small cavernoma you can see in the pontomedullary junction. And again, this is not a difficult case. We just need a good microscope, prone position. You can see that there is like a yellowish area, means a hemosiderin there. Then just clearly, and because this is located with superficial, we can remove without any problem. You can see this is the movement of the eyeball after surgery. And this similar case located in the pontomedullary junction, but deeper and more in the medulla. You can see even similar, but the effect is different. So I see we also again approach from the posterior approach, and you can see here. So after removal, everything okay, but slightly sixth nerve palsy after the surgery. So this is another case of pontine cavernous angioma. You can see here bleeding inside the tumor. You can see here. And I still prefer posterior approach for this gray area. You can see there's a medullary stria very clear because the white angle just split in the center. Because if you don't see any landmark, split in the center. And this is again the cavernoma. This is a young lady. And again, the prognostic should be very good. Then we remove totally piecemeal. You can see here. Finally, total removal is the target of the cavernous angioma. You can see here, we can totally remove just coverings, research the dura. This is post-op MRI. You can see here, and again, this is a young girl. 10 days after surgery, still plagia in the left extremities. But 1 month later, you see recover very soon because again, in children, is more indication. So this is the pontine cavernous angioma if the bleeding inside the capsule. So this is a subacute rupture pontine multiple cavernous angioma. The young boy came to me. You can see there is already multiple layer, means of bleeding many times in this boy. And if you can see clear, actually in the anterior also another cavernoma. But when he came to me, we decided to remove the big one in the posterior with the prone position. So again, this is diplopia and difficulty to walk. You can see here. We will meet the bleeding first, then the cavernoma later. So it's not so difficult. Again, the posterior approach, splitting Burmese about 1/3 lower will not a problem. We don't have any case of nudism. during splitting the vermis. Because again, when we do not split the vermis, means we need to retract more stronger. And I prefer to split, then retraction is not much. And again, we can see very clear. So again, this is the boy we can remove totally. And then he came to me, he played basketball. And later on, he is, I think, going now in UK for study. So this is the case of exophytic medulla. Of course, this is also not a big problem. So we do a posterior approach. You can see here, we need to open until the C1. You can see very clear here. There is a lower cranial nerve. There is like all of the vessel are here. And you can see this is the yellowish exophytic cavernoma. Then we just need to dissect clearly from the surrounding area. Then again, total removal is the target of the cavernous angioma. You can see this is in the medulla. But because this is exophytic, means that we shall not interrupt the medulla too much. So the effect is not bad, and the patient woke up clearly without any paralysis, just one day in the ICU. So this is after removal of the lesion. So this is 40 years old male with hemiparesis and lower cranial palsy. Again, this is the mass is in the medulla. Medulla is completely different with the approach in the pons. We know that medulla just maybe about 1/3 smaller than pons. And the medulla, many nuclei, lower cranial nerve, all there. So means manipulating medulla will have a more severe deficit. So in my experience, after medulla operation, the patient will have a tube couple of weeks and sometimes couple of months. I get also another experience from Japanese colleagues, the same, because medulla, even we approach as smooth as possible, but it still touch the lower cranial nerve and cause dysphagia and difficult to swallow. So again, this is the anatomy already explained by Thomas. And you can see here, prone position, there's a midline approach. So because the cavernoma is located not from the superficial, but beneath, then we need to strictly midline approach, go down, then we can find cavernoma is there. And again, very, very delicate approach, because medulla, very small, and then here, over there, so many nuclei. And remember, every manipulation will cause mostly lower cranial nerve palsy. And again, expectedly, actually temporary. You can see how terrible if the patient gets a permanent lower cranial palsy that we can swallow maybe long in the long life. So again, this is after slowly, piecemeal, delicate, very tiny equipment to remove the mass in the medulla. So again, completely different. So he used a tube 2 months after surgery. Fortunately, we can remove the tube 2 months after surgery, still fortunately. So this is the post-op MRI. So this is a rupture of the midbrain cavernoma. Again, this is the approach is not so difficult. We use subtemporal, transtentorial approach, and we just go there. It's not so much problem because the lesion also, there's a hemosiderin surrounding the lesion. So this is not a case like a unique case of lower pons, cavernous angioma. And in this time, we use a pre-sigmoid and sometimes maybe also retrosigmoid can find. You can see here, there's a young lady with a very big, with a hematoma ultimate inside. You can see here in the lower point. Then we open it here, you can see we can use like just as CPA approach. After leaking the CSF, you can see here, lower cranial nerve, 7 and 8 complex are here. Then we can see, just look, where's the color is different. You can see here, the color is a bit brownish, mean beneath this, like a hematoma of the cavernoma. So we can see that, okay, then we can decide there is the best entrance means that the most superficial entrance. You can see that after that, it just lytic hematoma coming out, then we can remove totally this cavernoma located in the lower pons location. And the patient gets soon better when she came to me with a hemiplegia, and then soon recover. And 3 months later, she walked, meet me in my clinic. You can see that's before and that's after surgery. So this is the lower pons cavernous angioma. So this is another unique case with a 29-year-old female with a bilateral paralysis and nerve palsy. This is a huge cavernous angioma located from the midbrain going to the pons. So what is the best approach for this? Because this question. So the the cavernoma is really very big. So this time you see that it's very big from the pons going to the midbrain. It's quite huge. Yeah, that's what the husband met me. So in this case, we decided to use like a sitting position because sitting position may be the best approach to this type. So again, the sitting position, of course, we need to be very careful, right? We need also to understand the risk of the sitting position. We need to have a very good anesthesiologist because they need to monitor the ECG. Be careful about the air emboli. It may happen quite frequently in the sitting position. But with this sitting position, we know that all collapse down, right? The cerebellum is down. You can see very clearly without any retraction. You can see here, right? So, well, of course, operator is quite tired because the position, but you see that. Then we go there, we can see the, deep in the about anterolateral. We can see, and this position really, you see, there's cerebellum going down, and then we can have a very good surgical field around there, right? This is the position is really very useful for the huge one, the cavernoma located in the midbrain pon location. You can see that, right? So it's very good because of falling down. You can see that you can find this is the cavernoma, and then again because of course manipulation will quite a lot because the volume is so big. But again, with this position, then we can go in, is quite nice. So again, we can do total removal after this position, sitting position. So this is the post-op, and the lady still came to me walking and with a mild paresis. This is not the case with a 60 years female with unconscious, unable to swallow, and heavy paresis. You can see here. And this is also located in the medulla, a cavernoma in the medulla. So we need to open like this, posterior approach, and we need to understand, you can see here, this is a cervical cord here. Then we need to know where is the cavernoma located because it's not appeared from the surface.
2 minutes, Eka.
Yeah, sure, almost. So we just incise in the anterolateral and we found this is the cavernoma. And the lady again still used tube even before surgery already with the tube. But fortunately, the lady 2 months also used tube and now can eating normal. So again, be careful. Manipulation in the medulla is completely different story with manipulation in the pons because again, very small and very compact with nuclear over there. So thank you very much for your attention and have a good night, good morning, good afternoon. Thank you, Vladimir.
Thank you, Eka. It was great. And thanks for keeping the time. So we are done with the lectures. And what I need to do is to thank all the participants because without you, it would be pointless to organize something like that. Then I would like to thank all the faculty, which I see now is present, all of them. And above all, I must thank Professor Imad Kanan, who was the driving force behind this all, and to him belongs all the credit for this extraordinary course. And this course will certainly be sending out evaluations, which those registered will receive within 24 hours. and we would like you to fill the form. It's 5 minutes work. Send it back to us, and within 7 days, all the registered participants will receive diplomas, which are very nice and very elegant. Thanks to Pablo who did them. So thanks again. We hope to organize next seminar in June. So hopefully you will all join again, and we believe that we shall prepare a nice program. And now that I see that Professor Kanan is present, Imad, would you like to conclude the thing?
No,
for
actually,
which
you've done the job, and we are co-chairing this committee. We are, as faculty, very pleased of the number of attendees that exceed 4,000 registrants. And this is, I think, one of the largest ever. And with this expected feedback coming, we are for sure will have the dynamic course coming again in June. And we will, of course, with the different topics and additional staffing. I thank everybody as well. Thanks, Vladimir.
Thanks.
I have to add, please, to Pablo, was an important part of this course, to Sanjeeva, who has given us the support and the initiative as well, and all the faculties. Thank you.
Imad,
Yes.
can I ask everyone to smile because I want to take a group picture in the lobby?
Lobby.
What about the dinner, Pablo?
Yes.
My house.
Well, I received a message on the phone from Giovanni. He said the next meeting will be in Ecuador. So I'm preparing myself for avoid the social distancing and jump on the flight. Let's hope the best and pray for everybody that will be safe and able to rejoin these activities in our traditional way as well.
Sure.
This is good.
Guys, has been fantastic.
Okay. All of us, very good.
Yeah.
All right. Bye-bye.
Bye.
Bye-bye.
Thanks,
Bye-bye.
No.
Next time it will be in Victoria Falls.
Yeah.
Yes. Very good.
We'll do.
Hi, Salman.
Hi. See you guys.
You must organize it in Harare again.
Sam,
Yes. No, Victoria Falls this time.
Victoria Falls.
Yes.
For sure. With Wange.
we have
Yes.
the K is waiting for us in Pakistan.
Sure.
Has to prepare everything.
Yes, of course. Yeah.
Definitely. Yeah.
And Mexico, of course.
Mexico.
The full program.
Hey.
Canada in the
Thanks,
summer is
everybody.
not so bad. We'll see what we can do for me.
Do not forget
Yes.
Maya. Come to
Isaac, okay.
Okay, guys. Okay,
Bye.
brilliant, guys.
Take
Bye-bye.
care.
See you.
Thank you.
Bye. See
Bye-bye.
you soon.
Very good.
See you.
Miguel Ángel, muchas gracias.
Congratulations,
Gracias.
Paulo. Fantástico.
Thank you so much. Nos vemos pronto.
Job.
Good to have you with us, Ramis. Take care. And Tanji, are you with us? Or I think Tanji is too late for him in China. Must be after hours.
They might be sleeping.
Hope we will have him next time with us on the as a presenter.
Rames, take
Tanji,
care.
I'm seeing you here in the OR. Yeah,
Thank you. Thank you.
take care.
Bye-bye, Matt.
Bye. Bye.
Bye.
Thanks a lot. Bye-bye.
Hola, hola.
No video.
No video. Yes, video.
What's that, Pablo?
Sanjeeva, I just stopped the recording and it's